Hi, Sirolimus is a macrocyclic 3N antibiotic that's produced by fermentation of Streptomyces hygroscopius. Sirolimus was first discovered from a soil sample collected in Easter Island. Although it was originally developed as an antifungal agent, it was later found to have immunosuppressive and antiproliferative properties that may be useful to treat or prevent proliferative diseases such as tuberous sclerosis, psoriasis, and malignancies. Following entry into the cytoplasm, sirolimus binds to the FK binding protein and presumably modulates the activity of mammalian target of rapamycin, mTOR. The mTOR inhibits interleukin-2 mediated signal transduction, resulting in cell cycle arrest in the J1S phase. Sirolimus blocks the response of T and B cell activation by cytokines, which prevents cell cycle progression and proliferation. In contrast, tacrolimus and cyclosporin inhibit the production of cytokines since there is activation of the sirolimus target in tuberous sclerosis lesions may dampen the growth of angiomyolipomas with tuberous sclerosis. To minimize variability caused by food, we prefer to have patients take sirolimus at 8 a.m., usually 1 to 2 hours after food ingestion. The time to peak concentration of sirolimus oral solution is 1 to 2 hours. The rate and extent of oral absorption of sirolimus may be reduced in blacks. The absorption of sirolimus is altered by concurrent food intake. Sirolimus is extensively metabolized in the liver. It's a substrate for cytochrome P453A4. Total body clearance of sirolimus is 127 to 240 ml per kilogram per hour. 45% higher clearance is known in black patients. Excretion is 90% by the biliary system, which means excreted in feces, and about 2% is excreted in urine. Elimination half-life is 57 to 63 hours. Sirolimus is available in oral solution or tablet forms. Organ impairment and sirolimus is an important point. Dose adjustment of sirolimus is not required in the presence of renal impairment. In contrast, dosage adjustments are needed in the setting of liver disease. Dosage reductions of approximately 1/3 the normal maintenance dose should be used for patients with hepatic impairment. Close monitoring of whole blood concentrations are recommended. Steady-state concentrations of sirolimus occur 5 to 7 days after initiation therapy or a change in dosage. Routine therapeutic drug monitoring is not recommended for the majority of patients. Monitoring is recommended in the following situations or groups: pediatric patients, patients with hepatic impairment, patients receiving CYP3A4 inducers and inhibitors, patients in which the calcineurin dose is markedly decreased or discontinued. The recommended time for collection is 1 hour prior to the next oral dose. Whole blood samples should be collected in tubes with ETA and protected from light. In 2 multicenter randomized trials in de novo liver transplant recipients, the use of sirolimus in combination with either cyclosporin or tacrolimus was associated with an increased rate of hepatic artery thrombosis. According to a study published in Transplantation in 2004, the most common side effects of sirolimus included bilateral lower extremity edema, dermatitis, oral ulcers, joint pain, pleural effusions, increase in abdominal girth, generalized edema, pericardial effusion, and facial edema. Metabolic effects of sirolimus include hyperlipidemia, which is seen in 38 to 57% of patients, and hypercholesterolemia in 38 to 46%. Those related effects of sirolimus therapy and occur via the inhibition of lipoprotein lipase. In one study of 26 patients, triglyceride levels exceeding 5 mmol per liter or 454 mg per deciliter were seen in 75% of patients receiving various doses of sirolimus in addition to cyclosporine-based regimens. Despite these effects, sirolimus has been demonstrated to help prevent atherosclerosis in murine models and in heart transplant patients. Side effects of sirolimus may include mouth sores not related to herpes simplex virus. In addition, constipation is one of the most common side effects involving gastrointestinal tract. Diarrhea similarly is seen 25 to 42%. Dyspepsia is seen 17 to 25%. Nausea is seen as often as 25 to 36%. Respiratory system and sirolimus is important to note. Progressive interstitial pneumonitis has been observed in a number of transplant recipients. Clinical symptoms consist of dyspnea, dry cough, fever, and fatigue. In one report of 24 patients, radiographic and bronchoalveolar lavage principally revealed bronchiolitis obliterans, organizing pneumonia, and lymphocytic alveolitis. Complete recovery was observed in all patients within 6 months of sirolimus withdrawal. In a study published at Annals of Internal Medicine 2006, out of 217 renal transplant recipients, 11% developed pneumonitis. These patients had a median trough level of sirolimus of 20 nanogram per deciliter. Patients had received sirolimus for a median of 5.5 months before respiratory symptoms emerged. Most common respiratory symptoms included cough, fatigue, fever. In the same study, computed tomography of chest showed patchy bilateral asymmetrical peripheral consolidations consistent with bronchiolitis obliterans, organizing pneumonia. Almost all patients had full recovery in 6 months after discontinuation of the medication. Here the posterior anterior chest radiograph shows bilateral peripheral pulmonary infiltrates. Chest radiograph obtained before the patient's illness shows normal findings. The next or lower images are computer tomography of chest using 5 mm slices without intravenous contrast medium, showing a predominantly peripheral bilateral ground glass alveolar infiltrates. The bottom image is also a computer tomography 4 months after sirolimus was permanently discontinued, revealing no evidence of bilateral ground glass infiltrates and a significant recovery. Sirolimus has some effects on kidney function. It's known to be nephrotoxic in animals. In humans, it's not well proven at this point. The combination of sirolimus and cyclosporin has caused a synergistic nephrotoxicity in animals and humans. Delayed graft function and CAS nephropathy associated with tacrolimus plus rapamycin use is proven as per a study published in Journal of American Society of Nephrology in 2003. All biopsies during episodes of DGF demonstrated chains of acute tubular injury. Of the patients with tubular injury, 12 treated with rapamycin and tacrolimus developed intratubular CAS formation indistinguishable from multiple myeloma CAS nephropathy. Histologic, immunohistochemical, and ultrastructural studies indicated that these casts were composed at least in part of degenerating renal tubular epithelial cells. These findings suggest that rapamycin therapy exerts increased toxicity on tubular epithelial cells and/or retards healing, leading to an increased incidence of DGF. Additionally, rapamycin treatment combined with a calcineurin inhibitor may lead to extensive tubular cell injury and death, and a unique form of CAS nephropathy. Proteinuria following a switch from calcineurin inhibitor to sirolimus has been studied. In a retrospective study, 68 renal transplant recipients were switched from calcineurin inhibitor to sirolimus. Proteinuria was measured using 24-hour urine collection before the switch and collections on 3rd, 6th, 12th, and 24th months thereafter. In addition, proteinuria was measured in patients who had to be switched back to calcineurin inhibitor due to side effects. Baseline proteinuria was 0.39 gram per day in all 68 patients. It's noted that there was mean protein loss of 1.44 gram per day at 3 months. Mechanisms of proteinuria are blamed on reduced tubular protein reabsorption, podocyte dysregulation, overexpression of endothelial growth factor that enhances cell wall permeability, leading to collapsing focal segmental glomerulosclerosis. A unique form of CAS nephropathy has been described in a few patients with delayed allograft function and extensive tubular damage who were being administered tacrolimus plus sirolimus. CAS were histologically indistinguishable from those observed with myeloma nephropathy. PTLD is uncommon, and actually sirolimus may have anti-malignancy effects. Teratogenicity effects in pregnancy are important to note. Sirolimus is contraindicated in pregnancy and its use should be discontinued at least 12 weeks prior to attempted conception. In 2 case reports, sirolimus has been associated with development of leukocytoclastic vasculitis. In some rare cases, tongue edema has been also reported. A large number of cutaneous adverse events can be observed with sirolimus. In one study from France, skin disorders were reported in 79 of 80 renal transplant patients. The most frequent were acne-like eruptions, seen in 46%, scalp folliculitis, seen in 26%, hidradenitis suppurativa in 12%, edema in 55%, angioedema 15%, aphthous ulcerations in 60%, and epistaxis in 60%. This picture shows painful nodular acne of the face and severe hidradenitis suppurativa. Severe edema might be seen, and typically it's generally a unilateral soft, non-inflammatory edema of the arm or legs. Bilateral scleroderma-like lesions of both legs can be seen. There are some limitations of initial use for sirolimus. These include delayed allograft function, poor wound healing, increased incidence of lymphocells. The use of sirolimus as a monotherapy is experimental and not well established.